Welcome to RUMC Connections. Richmond University Medical Center is a leading medical facility located in the heart of Staten Island. The Department of Rehabilitation Medicine features a team of dedicated practitioners who specialize in improving the abilities and livelihoods of patients. Together, therapists and patients work to achieve incremental goals on the way to successful rehabilitation. RUMC's team of experts include leading practitioners of occupational therapy, physical therapy, speech-language pathology, and physiatrists. Outpatient services are located at 288 Kissel Avenue on the RUMC campus. So once again, welcome and thank you for joining us, Kristine.
Thank you.
So as we mentioned, RUMC has an array of various adult rehabilitation services offered. What are the most in-demand services that adults are seeking at this time?
I would have to say probably physical therapy.
Okay.
For adults, because it encompasses not only after surgery and musculoskeletal pain, like neck pain, back pain, what we kind of all suffer from, but also neurological, so after stroke, patients with Parkinson's disease. So there's like a lot of demand, I think, for PT specifically for adults.
And what evaluations are done to determine a patient's course of treatment while these therapists are developing a program for them?
Each one of the therapists has their own assessments, but the assessments are standardized.
Okay.
So the patient comes for an evaluation, and there's a lot that goes into it as far as different tests. You know, standardized meaning like we kind of give a score so that we can give a measure for what is the pain level or what is the deficit level, and this is important for us to be able to track progress. So, and that's one part of it. Another part of it is developing patient-focused goals. So it's an important part of the evaluation process that when we have a patient who's coming in, they're usually not, we have to ask them, like, what do you hope to accomplish? Like, what is your goal? And usually it's not like, I want to get rid of my neck pain. Usually it's like, you know, when I'm driving, I can't turn my head and this, or, you know, I take care of my elderly mom and my back pain is not allowing me to do that. So our job is not just to like fix, you know, the problem and say, well, you know, your back pain, you know, you're saying it's better, whatever. We need to make sure that they can kind of get back to their life, because rehab is all about functional skills and quality of life. And that's what we're treating.
And these services are offered on RUMC's campus itself?
Yes, in the outpatient rehab building, which is the resident building on the back of the campus.
And it's all referral based, or can people make an appointment to come out on their own?
It's generally all referral based. We have patients who call and inquire, and then we'll just direct them to get a physician script. But if they don't say they haven't seen their primary care doctor, we have a physician on site. Dr. Hassan is our physiatrist. It's a rehab physician, so he can see the patient and he can do an assessment and he can actually order the service, the physical or the occupational or the speech therapy. He can write the referral. So we do have that as well. If the patient hasn't seen their doctor, but is maybe having back pain, that's one of their options.
And in our last episode, I know we spoke about the pediatric rehab program and how fantastic it is and such longevity that you have with some of the patients. Is it the same with the adult program? What is the typical amount of time that some of these patients are with the program?
So it depends on what the issue is. So sometimes it's, you know, maybe 6 weeks, 12 weeks, depending if it's like a post-op case, right? But we see the more longevity with our patients with neurological issues. Okay. So if they have, you know, MS or they have a stroke, brain tumor, we have patients with traumatic brain injury. Those patients we're going to see much longer because the rehab process is much more complex because there's a neurological component. And those patients we can treat for, you know, a very long time. Of course, we have, you know, we're guided by insurance authorization and whatnot, but they definitely, the need is there for a much longer time, and the progress is much, you know, much different, course.
And about 5 years ago, I know your center added cardiopulmonary rehabilitation
Yes.
to the mix because there was that was a service that was missing
Yeah.
on the island. Everyone had to go off island to get cardiopulmonary. How has that been? How's that grown over these years?
Can you tell me before you touch on that? Can you say what cardiopulmonary rehab is?
Yes, sure. So cardiopulmonary rehab it's a rehab program. It consists of exercise, monitored exercise. So the patient comes and they're going to be exercising, like say on a treadmill. They're going to be doing some like on a recumbent bike, but the patient is on a monitor and a nurse is present to monitor them for the first half of the program. So the first half is about 36 visits, which they can do in 12 to 18 weeks, depending on how often they come. The second half is unmonitored for the same amount of time, 12 to 18 weeks. So a patient who, say, has a heart attack, right, it's important, very important, that they don't remain sedentary, that they get back to exercise. Even if they didn't exercise before, they need to kind of rehabilitate their cardiopulmonary system. But, they can't go to a gym, right? It's because there's a high risk and people are afraid so they come and they exercise and they're given, it's a progressive program. So the nurse will determine what level they could start at and they progress from there. They're always monitored. So we've had, it's not often, but we've had situations where they need to have an EKG right on the spot or right in our building, we can offer that. Or they need to be sent to the ER. But this is the benefit because it could make a difference between having that episode someplace else where there's no medical
Like a private
professional.
office, and here you're only feet from an emergency department.
Exactly.
Yeah.
So that is our cardiopulmonary program, and it's been great. I have to say, because the patients love coming. It's like exercise in groups. So they have an 8 o'clock group and 9 o'clock, and it becomes like this social hour for them, and they're all talking about what happened to them. And by the end of the time, I remember the first group that we had in 2018 we opened, they were out for breakfast every day after their session.
That's great.
It was a bunch of older gentlemen, and they would go to the diner. It was the cutest thing.
Hopefully not eating bacon.
Exactly. And the nurse would be
Cheeseburgers.
watch what you eat. But
How
it's
funny.
actually a great program, and it also we dive into nutrition, and lifestyle changes. So
Right.
if someone smokes, we work on sending them to the referral for smoking cessation, nutrition, so they can change their diet.
Is that
things like that.
pre-stress test, or is that kind of the same thing?
It's usually after. It has to be after a cardiac event. There's a very specific list of people that can enter into the program. They have to have a qualifying diagnosis. And then we require the stress test. So the physician who refers will give them all the battery of tests. And then our physician, who is Dr. Grobman, he's our supervising physician. He will see the patient before. And Dr. Diaz is our pulmonologist, who's our supervising physician for pulmonary rehab. So if COPD, for example, we'll see the patient prior to them being able to start and making sure that they're safe and that they're a good candidate.
It sounds like with such an array of cases and patients that you see, are the majority of these patients receiving other services at RUMC? And if they are, how closely are you working with these other departments?
We work with a lot of patients who are undergoing cancer treatment.
Okay.
Cancer rehabilitation is actually a big part of what we do, specifically for patients who have lymphedema because they're receiving radiation. So we do have to work closely with the radiation oncology team, the medical oncology team, because we have to know where they are in their treatment. It's going to where they are in their treatment is going to depend on our course of treatment. So we work closely with them, and then also nutrition services. We'll be working with our head and neck patients, so we collaborate with them as well.
Staten Island was a hotbed for COVID-19 during the pandemic, and you have a lot of people that are still experiencing long COVID or the symptoms of COVID to the point that RUMC opened its own post-COVID care center sponsored by Investors Bank. They came in and helped us to set this comprehensive center up, and I believe that you've been part of that center in rehabbing patients, both because of the impact to their heart and lungs,
Yes.
but also people who were intubated because of COVID.
Yes. We saw a lot of patients post-COVID that were intubated and had laryngeal trauma. So it's like trauma to the larynx, the throat, who maybe like they had hoarseness or, swallowing issues that persisted. And then patients who need pulmonary rehab because of COVID and also cardiac. So we definitely saw a lot of effects, and we still are seeing effects of long COVID.
That was the first of its kind in the city, right? That opened?
We were the first on Staten Island that we opened, one of the first in the city. A lot of it was driven by, I know because we were in the hospital before you actually came on, Meredith, but you were pulled into duty.
Yes.
in basically RUMC became a COVID hospital. Yes. Outside of births and emergency surgeries, everyone was there with COVID. Several of our units were turned into ICUs. Kristine, I saw many times, was working in those. And Kristine and her team, and I'm going to let her talk. Am I talking for you like you're not here? There was a procedure called proning.
Yes.
That actually turned out to be very effective in the treatment of patients. I'll let you explain what that is.
When COVID hit, the peak of it, I remember, was like April 15th. Was, I think, our worst day at RUMC, right? We had the highest census and the most amount of deaths. So that was the day that we had initially started the proning, initiative, where proning is when you put a patient who is usually on a ventilator onto their stomach, and putting a regular patient on their stomach is not an issue, but when you're attached to a ventilator and highly sedated, it's a very precarious task and requires a team. There's a lot of research on this method, but it's not really used often, and it became like the last resort, kind of like a necessity during COVID. I was told, listen, your team is going to be the one doing all the proning. And we did it. We had to basically get a quick education on how to safely perform this, and it's like it's a very kind of specific way to like wrap the patient in the sheet, turn them, how to disconnect the ventilator, disconnect the the NG tube. Like it's a whole process, and it was tough on the staff. They went through a lot because some people, they didn't have a good outcome because that was COVID. It was something I'll never forget, and my staff will never forget. But actually, the results were, in some cases, amazing. People who were satting, like their oxygen level was like 60. We turned them on their stomach, it would go up to 85, 90. Wow. We saw things that, we never thought. So as much kind of as bad happened during COVID, I feel like we contributed to some of the good outcomes.
How many people are on your team that would do that? Like how?
So typically our team is split between inpatient and outpatient, but because we closed, the outpatient, we were all in the hospital, and it took 6 of us. I mean, there's like 20 of us total, but it took 6 people every time to prone, and they get prone twice a day. So it's like a 16-hour on their stomach. So there's a team that needs to prone and a team that needs to deprone, and it's 6 people. So, and we couldn't rely always that, we couldn't always send 6 therapists because we were all over. So we would rely on the help of the nurses, the respiratory therapists, like all the doctors, even everyone had to pitch in, and everybody was great. It was just another kind of example of how we have a challenge and we just rise to the occasion, I think, at RUMC, I feel. I mean, 10 years I've been at RUMC, this is what I feel, we're good at.
So it must have been nice to get back to business as usual, so to say.
Very much so. I feel like my staff was going to kill me by the end of it. They were like, I was like, if I asked them to do one more like out of the ordinary thing, like it was just like every day was like weirder than the next. So it was very nice to just, everyone went back to their routine, and I was like, no one complain about anything from now on.
But so now you're also, you talked a lot about rehab after a procedure, but you're also seeing injuries, workplace injuries, and assessing those. And sometimes I guess there's that people want to rush through their rehab. They want to get back to work. They want to get back to normal. How do you manage someone's expectation when clearly you can see that this is going to be a long haul to get you back to where you need to be?
I think it's a lot of education to the patient, and also they have their part in the rehab. So we explain to them from the very first day, you're going to given home exercises, and you need to do them. And it's like your homework, and people are like, yeah, I'm not doing that. But they they realize, like, you're not going to get better. Like, therapy is twice a week. Sometimes the max is like 3 times. You're not going to get better twice a week for an hour that you're coming. You need to really do your piece at home. Sometimes it's a lot. It takes some patients longer than others to realize, like, I need to put the work in. Can't just go through the motions because you're not going to get better.
Do you have a particular patient or experience that kind of sticks in your mind as a really positive, like, this is why I got into the field?
I worked in brain trauma for a while in the beginning of my career, and I have a lot of patients I distinctly remember, but I have this one patient who is about 19 years old, and he was in a horrific car accident and had a massive head injury. So he was what you call, like, in a minimally conscious state, which is a couple levels above coma, and which is another little known thing about rehab. We work with patients who are just emerging from coma. Even though you feel like, what could you do? There's a lot that we do. So we were working with this kid. Every single day his mom would come at the same time, and she'd say anything, because, he wasn't talking, any little thing you could say, like, you try to bring them something, right? But it's hard because you don't really have a lot. So I was working with him for a long time on, because I was a speech, on the staff or speech at the time, on making sounds. And I said, well, if there's any word we're going to work on, it's mom, because this is what would be the best thing for her to hear. So we worked on the M sound, and we worked, and eventually we got to the point where one day he said it. He said, mom, right? And thank God there was another therapist in the room with me, because I would have thought maybe I was imagining it. So I said, okay, we're going to do this like the rest of the day until mom comes.
Yeah.
And then she showed up, and I said, come on, I want to show you. We have something to show you. He did it. Like, he said, mom, when she came in the room, and when I tell you, I will never forget him, her expression. Like, I'll never forget that. And that's like what you kind of, the days when you feel like, like you just feel down and out, or the days when you feel like you're not really making a difference, this is the kind of stuff you have to think about, because this is something that was changed her life, and just made her, turned everything around for her. So he sticks out in my head. Yeah.
Of course. No, that sounds like an unforgettable moment for sure. And I mean, I'd like for you to touch a little bit more on this adult speech pathology, because I feel like a lot of people don't understand what it is. Yeah, and it is offered both in and outpatient at RUMC, right?
I spent my career as a medical speech pathologist, which most people don't think about. They think about working with children in a school. So it's not well understood. And if I had $1 every time I walked in a room, I worked in the hospital like mostly my whole career. And I introduced myself, I'm a speech pathologist. I said, I don't need a speech pathologist. I know how to speak. But what we do in the hospital mainly is swallowing. So I say, no, I'm here because of this or that. So it's not understood, and there's so much in the field that, like, so much we can really help people with. So specifically what I used to work with patients was on when they're on ventilators and after head and neck cancer. So patients who are on ventilators, they're not able to speak because of the way that the tubes are, like, disrupting the airflow. So one thing that we would do with, like, these types of patients is we work with speaking valves. We place a valve. It's a process, but we place a valve, and allows them to actually speak, which is another kind of amazing thing, because people look at a patient on a ventilator and they assume they don't know what's going on. They have nothing to say, but really they do know what's going on a lot of the time, and they would like to be able to say, like, I'm in pain, or talk to their family, or talk to the nurse or the doctor. So that's something a speech pathologist does, which no one will ever guess that, like, ever. And it also helps the weaning process. Weaning is like when they're getting off the vent. That will help the weaning process. It helps the patient become more comfortable. It helps them be able to get back to eating and drinking. And then as far as, like, for example, head and neck cancer, patients who are diagnosed with head and neck, we have a great radiation oncology team and medical oncology team at RUMC, and they are great about referring patients to us who are diagnosed. The patients are hesitant at first because they're like, what do I need you for? So we explain to them, listen, you're going to start radiation, it's going to get very hard to swallow. You're going to have a lot of pain. You know, you can aspirate things and go into your lungs. So we work with them from the very beginning and sort of throughout their radiation treatment and after. And this is something that can make the difference. And I've seen both sides. It makes a difference between someone sometimes never being able to eat again and needing a feeding tube and not needing a feeding tube. Huge difference. Another thing that speech pathologists do that nobody really knows that we do. But it's a service that for patients like this is tremendous.
And when you're talking about patients that have been ventilated, you're not talking someone that's been ventilated just for surgery. You're talking someone that's been a prolonged period of ventilation.
Someone who's on like in the ICU and needing a vent for a long time, or has a tracheotomy placed, so they're off the vent, but they still need a trach. Same situation. Like we would use speaking valve. We work with their swallowing. The thing about speech, which is the medical speech pathology, is that we work on, someone who had a stroke and they can't speak, or their speech is very altered, right? They can't get words out. So speaking, right, swallowing, which is what, eating. So these two things, communication and eating, this is two of the biggest quality of life things that we have as humans. When I've been told in the past, like, you're a speech therapist, like kind of like, what do you really do? And I said, well, if you can't eat or you can't speak, then, I think you would appreciate what a speech pathologist does. I just like to highlight that because it's how I spent my career, and I think it's important for people to know.
Absolutely.
So you're making a difference every day. What about you? Tell us a little bit about yourself. What do you do in your downtime, if you have it?
I do have downtime sometimes. So I spend time with my daughter. She's 11 and keeps me on my toes. And I love to cook. I like to go out and eat, too. I'd say, like, I'm Italian, so I grew up and we only ate Italian food because that's just like, I don't know what you do when you're Italian.
It's just food, yeah, exactly.
Right. So and I never had, there's so many different kinds of cuisine I never had. So as I got older and I started to eat places that weren't Italian, I said, oh, wow, there's like all this different stuff to eat. So I love to cook, so I like to like cook at home and try different things that like, I wouldn't have
What's your signature dish?
I make a lot of Middle Eastern food.
Really?
And I just
You're talking about Italian.
I'm just saying, it's like something I would have eaten growing up. I've made like a lot of Middle Eastern food. I made what I make the other day, lo mein, which I love eating out, but I was like, I'm going to try it. Yeah. So I like to cook. I like to read.
All right. Well, the $1 million question is Italian. Is it gravy or is it sauce?
It's sauce.
There you go. Solved.
There you go. Solved. Sunday sauce.
And that's an official statement.
And are you from Staten Island? You were born and raised in Staten Island?
Yes.
Yeah. That's always, that's one of the things about RUMC is you walk around the hall as you talk to people, you find so many people are Staten Islanders. They either were born and raised here or native Staten Islanders, or they moved here. And it does bleed into the culture. It's
Absolutely.
And you can see it when you talk to patients because you now have a common bond. Everybody kind of knows them all. They know certain things about Staten Island. You can talk to some of the senior patients that we have who remember before the Verrazano was built and having to go up Jersey into the Bronx, and it does bleed into. It gives RUMC its personality.
What high school did you go to?
Susan Wagner.
There you go. There you go.
And then you usually, you meet people, and it's like I feel like everyone knows everyone. Sometimes it feels like a very small, right? Like you end up knowing somebody that you went to high school with, or they went to the same high school.
Yes.
So, yeah, Staten Island is unique, and RUMC's like kind of the microcosm, I think, of Staten Island.
As someone who's originally from Queens who now lives on Staten Island, I find that very difficult. I find it amazing that anyone in Staten Island gets away with anything because everybody knows somebody.
They don't.
Yeah, it's like, you break a law, you probably know the arresting cop before he even arrives on the scene.
Yeah.
So, it's very, very interesting, but I think it also, it comes to that. We always talk about you can't leave the borough without paying a toll or so far. But when you can get services like everything you just described, and it's basically in your backyard, there the bigger component, we've talked about this with many of our guests on our show, a very big component of the recovery process, I'll say the rehab process, is being home, being in a familiar setting, You know, whether you're doing the exercises you're supposed to do at home,
Right.
the fact that you are in your home setting means a lot, as opposed to, you know, if you're just after a major surgery or an injury where you may be having to go to rehab 2 or 3 times a week,
to
commuting
travel.
to Manhattan or Brooklyn or
Yeah.
New Jersey 3 times a week. And here you may have but it's a couple of,
Yeah.
depending on traffic on Staten Island,
Yeah.
it's a
But it's
relatively
here.
short, but you're
No
here.
more than 30 minutes.
It's a
No more than
relatively
30
short
minutes.
trip. Yeah.
Exactly, but you're here, and that's something that our patients that have been admitted have said, you know, you're in a hospital in Manhattan or Brooklyn, you may have family members that can't get to you, and you're
Yeah.
now in your room with no one to help you in the healing process.
Yeah.
But if you're here on Staten Island at RUMC,
Yes.
your relatives are here. They're a drive away.
Yes.
Some of them are, you know, can walk to RUMC.
Yeah, we have people that, you know, they actually walk to their rehab. I mean, usually not physical if there's, but like if there's other issues, they walk to the rehab because they're living so close. We
Right.
offer the hours. We're open at 7 a.m. So people come, a lot of employees, they come before work, you know, because we open so early, and then we're open till about 6 or 7 most nights. So we have the flexibility, and like we said, we're local and, you know, to the island.
No, that's great. And as the director of the program, is there anything that you hope to see for the future of the program, or with any advances in technology, is there anything that's changing or that could help you down the road?
I think definitely just like adding some equipment, like the technology piece is becoming big in rehab. So I think adding, you know, into the technology piece, I think would be a big asset for us. Some ancillary services, you know, not to benefit every patient, but there's art therapy, there's music therapy, there's, which is not only for pediatric, there's actually a lot of research for neurological patients who have had a neurological incident, horticulture therapy. There's like a lot of different things different fun experience for the patient, but also achieving a result at the same time. So I guess like I would want to venture into just some different things we've never tried.
Yeah. Oh, it sounds like it could be
It's
very
like
beneficial.
Cooking
disguising
therapy.
therapy. You know?
Yeah.
Yeah,
Cooking
exactly.
therapy.
Cooking there you go, there you
Actually,
go.
my speech therapist she keeps asking me. She's like, "Can we do a cooking class?" I'm like, "There might be a lot of red tape." I said, "But I will figure it out and see if we can do it."
Well, there is a new kitchen incubator that's going to be opening on the island that you'll be able to have access to utilizing that space, and
That would be, yeah.
it's open to the public, so it'd be something that you'd be able to take advantage of.
One thing also, which I'd like to see, we would need definitely more space, but sort of like they do like little cities, some of the rehab places that they have a car, you know, they have a kitchen set up so that the patients they can actually work on getting in and out of the car. They can work on like getting their way around the kitchen. So things like that would be something nice too to add. It's just a thought for the future.
Absolutely.
Yeah.
Well, thank you again for joining us today, and thank you
you.
to everyone for listening. That about does it for this week's episode of RUMC Connections. I'm Meredith Gaskins.